Good morning. This is the second lecture of the female genital tract pathology. Today we will be discussing diseases of the vagina and the cervix. The vagina can be affected by vaginitis or some malignant neoplasms. Those neoplasms are most commonly squamous cell carcinoma, adenocarcinoma, or sarcoma. Vaginitis is an inflammation of the vagina. It's typically transient with no clinical consequences. It can be caused by a variety of organisms, bacteria, viruses, protozoa, or fungi. Many of these are normal flora of the vagina, and they become infective in the setting of diabetes, immunodeficiency, pregnancy, or recent abortion. The common denominator of these factors is either decreased immunity or change in the pH of the vagina that results in predisposition to infection. For example, Candida, which is considered normal flora in about 5% of women, can result in white, curdy discharge, specifically in diabetic women. Trichomonas vaginalis produces a green discharge. It is a sexually transmitted disease, and it's typically asymptomatic in men and asymptomatic in 50% of women. Malignant neoplasia of the vagina, they are exceptionally rare. The most common variant is squamous cell carcinoma. The cases are associated with human papillomavirus and a precursor lesion named vein or vaginal intraepithelial neoplasia. Similar to squamous cell carcinoma of the vulva, it affects elderly women. However, if you remember, the vulvar squamous cell carcinoma associated with HPV affects women who are in middle-aged, and the squamous cell carcinoma of the vulva that is not associated with HPV is the one that occurs after the age of menopause. Another variant of carcinoma is the clear cell adenocarcinoma. This is exceptionally rare nowadays. It was more common in the 70s when women used to receive a medication called diethylstilbestrol. This medication is no longer used, and it was used to treat threatened abortions. This medication sometimes results in vaginal adenosis, increase in the glands of the vaginal wall, which is considered a precursor lesion for adenocarcinoma. They look like red patches of the vaginal wall, and the number of cysts lined by mucus-secreting columnar epithelium is also increased. Sarcoma botryoides, it's a subtype of rhabdomyosarcoma. It affects girls younger than the age of 5, although it can happen basically at older ages. It's commonly less than the age of 5. It presents as a polypoid mass protruding from the vagina. And again, it is a subtype of rhabdomyosarcoma. The cervix is part of the uterine corpus, and it can be affected by cervicitis or by neoplasia. Cervicitis is very common. It results in discharge through the vagina. It can be infectious or non-infectious, and it's difficult sometimes to differentiate between the two because of a lot of these organisms are actually normal flora of the cervix. Chlamydia trachomatis is the most common cause of cervicitis. Ureaplasma ureaticum, Trichomonas vaginalis, Neisseria gonorrhea, herpes simplex 2, and human papillomavirus. Please remember, in addition to neoplasia, human papillomavirus can also result in cervicitis. Cervicitis could be acute or chronic. Acute cervicitis is relatively uncommon and occurs typically in the setting of postpartum women. It's caused by bacteria, staph, or strep. Chronic cervicitis is the presence of chronic inflammatory cells in the cervix with regenerative changes in the epithelium with squamous metaplasia. This is very common in women. Most neoplasms of the cervix are epithelial and the most commonly associated with human papillomavirus. Remember, the cervix has two types of cells lining it. The upper half, represented by these blue bullets, is the glandular epithelium, composed of mucin-secreting columnar cells. The lower part, which is represented by these yellowish flat cells, is the squamous epithelium. The junction of the columnar and squamous epithelium is called the transitional zone, and the human papillomavirus has tropism for that region. Most infections by human papillomavirus are transient and eliminated by the immune system within few months. Small subset of these will persist, and even a smaller subset will progress to neoplasia. What are the risk factors for acquiring human papillomavirus? HPV is a sexually transmitted disease. Early age at first sexual intercourse, multiple sexual partners, male partner with multiple previous sexual partners, and persistent infection by high-risk strains of HPV are all risk factors for developing cervical neoplasia caused by human papillomavirus. What does the human papillomavirus do? Well, the HPV is a DNA virus. It has several segments of its gene that integrates itself in the host DNA, the human DNA. This will cause suppression of certain tumor suppressor genes, specifically RB and P53, which results in uncontrolled proliferation of the tumor cells. Also, the DNA segments of the HPV results in amplification or overexpression of certain tumor oncogen, specifically MYC, again further supporting the uncontrolled proliferation of cells. There are two types of human papillomavirus, the low risk and the high risk. The low risk causes condyloma and no cancer. The high risk ones are the ones that produce CIN and invasive cancer. CIN stands for cervical intraepithelial neoplasia. It's a precancerous lesion before the development of invasive squamous cell carcinoma. This is a schematic representation of the two types of HPV. On the left-hand side, we have the low-risk HPV. Notice that the viral DNA does not integrate into the host DNA. And so the production of the E6 and E7, these are the DNA segments from the virus, are not overexpressed. And so expression of the oncoproteins that results in the proliferation is not high. That's why these low-risk viruses do not result in cancer. On the other hand, the high-risk ones, such as HPV 16 and 18, actually integrate themselves into the human DNA. This will result in overexpression of E6 and E7. Also, it will result in suppression of P53 and RB and overexpression of MYC. The result is proliferation and development of cervical intraepithelial neoplasia and subsequently cancer. Thankfully, not all cases will develop into CIN or carcinoma. Notice that the vast majority of low-grade intraepithelial lesions will actually regress. 30% of them will persist, and only 10% will develop into high-grade intraepithelial lesion. The high-grade intraepithelial lesion, which is composed of cervical intraepithelial neoplasia 2 and 3, and we will talk about these in a minute, 30% of them regress, 60% persist, and 10% of these will develop into invasive carcinoma. That means that human papillomavirus by itself is not sufficient to drive the neoplastic process, and other factors should be employed to result in invasive carcinoma. These factors include other STDs, host immune response, mutations in other genes such as LKB1, smoking, and human immunodeficiency virus. Well, what is CIN, or cervical intraepithelial neoplasia? It is a precancerous lesion. It precedes invasive carcinoma by years to decades. The peak incidence of CIN is the age of 30, while the peak incidence of invasive cancer is 45. CIN can be divided into CIN1, CIN2, and CIN3. CIN1 is considered low grade. CIN2 and 3 are considered high grade. This image shows normal mucosa at the upper left side, normal squamous epithelium of the cervix. The right upper image shows CIN1. The changes of proliferation are restricted to the lower half of the epithelium, while the upper two-thirds of the epithelium are normal. The lower left image shows CIN2, where now there is widespread proliferation involving the lower two-thirds of the epithelium, while the surface of the epithelium is flat and normal. Finally, the left lower image shows CIN3, in which the neoplastic proliferation involves the whole thickness of the epithelium. In CIN1, 2, and 3, the epithelial basement membrane is intact and there is no invasion to the underlying tissue. When talking about cervical neoplasia, it is very important to discuss the Pap test, formerly known as the Papa-Nicolau smear or the Pap smear. The Pap smear is one of the major success stories in medicine. Please remember, in the beginning of the last century, cervical carcinoma was one of the top killers of women. Cervical cancer now, it's not even on the top 10 of cancers in women. And all of that is thanks to the development of the Pap smear or the Pap test. The Pap test basically is when the physician takes a sample from the cervix, a cellular sample, and we look at it under the microscope. There are some findings that suggest intraepithelial neoplasia. The left-hand side image shows normal squamous epithelium. Notice the small nuclei. The right-hand side shows low-grade neoplasia, in which the nuclei are somewhat enlarged, irregular, and hyperchromatic. These two images show high-grade intraepithelial neoplasia. Notice now how enlarged the nuclei are, so that the nuclear to cytoplasmic ratio, the NC ratio, is high. Notice the irregular nuclei and the hyperchromasia as well. The Pap test is a screening test. After the patient is found to have cervical intraepithelial neoplasia by Pap smear or Pap test, she should undergo colposcopic examination and possible biopsy. And based on that, treatment will be employed. The success of Pap testing comes from the fact that we can detect cervical neoplasia at an early stage before it has invaded into the surrounding tissue or resulted in distant metastasis. Recently, there is a quadrivalent vaccine that has been developed involving the four major strains of cervical neoplasia, whether it was condyloma or CIN. These include strains 611, the low risk group, and 16 and 18. These are very effective in preventing HPV infection and subsequent neoplasia. Even more recently, a 9-valent vaccine has been developed for more strains of the virus. Invasive carcinoma of the cervix most commonly is squamous cell carcinoma. Around 20% are adenocarcinomas or mixed adenosquamous carcinomas, and small cell neuroendocrine carcinoma represent less than 5%. All of these subtypes are caused by human papillomavirus infection. Grossly, these tumors are composed of either small and superficial or large and exophytic masses that might result in obstruction of the cervix. Lymph node involvement and risk of distant mets are always there and correlate with the depth of invasion. This is an example of cervical invasive malignancy. Notice that the lumen of the cervix is filled with this red glistening mass. This is squamous cell carcinoma. This is a histological image of squamous cell carcinoma. Notice that the arrows are, the long arrows point to tongues and fronds of malignant squamous epithelium that has invaded into the subepithelial tissue. This invasion results in desmoblastic response, which is basically edema and fibrosis. Clinical presentation of the cervical epithelium is carcinoma is either asymptomatic, caught on Pap smear, which is the most common presentation nowadays. And if the patient never had a Pap test, she might present with vaginal bleeding, dyspareunia, which is a pain upon sexual intercourse. Again, typically happens in women who never had Pap smears. The outcome of the disease correlates with stage. And if the tumor is incurable, death ensues from local invasion rather than distant metastasis. Once again, thank you so much for listening. If you guys have any questions, please do not hesitate to ask. Please stay safe and talk to you later.